يحلو كلما كررته ولذاك عدت مكررا لحلاوته.
Attitude of the patient safety. First of all, about the nosocomial infection or ventilator-associated pneumonia we're going to talk about. Why it is important to get an idea about such kind of infections. Because it affects mortality and morbidity. As Dr. Hakim said in the last lecture, if you remember, if you have one baby with a picture of BPD, bronchopulmonary dysplasia, and has got this bad infection, simply you lose your baby. If there is no active and immediate interaction, simply you lose your baby. So it actually affects the mortality, and again affecting the morbidity. There will be long stay in the hospital. You are going to start antibiotic for considerable duration. So there is a prolonged hospital stay. There is financial burden and the cost for the patient as well as the hospital, and it's something actually preventable. And as we'll see by the end of the lecture, how we're going to adopt a bundle chain. How can we prevent this community acquired infection? By just simple ways, we can avoid all these drawbacks. They are telling nearly about 2 million nosocomial infection in USA annually are recorded, and nearly 90,000 deaths yearly also, and financial burden, as we said, nearly 4.5 billion in excess of the healthcare costs annually. 30% of all ICU patients, in general, not pediatric or in ICU, all ICU are diagnosed with this nosocomial infection. This is the definition for nosocomial infection or community acquired infection before. Are telling any infection the patient got acquired in a hospital setting, that's not business admission. Patient admitted and then start to develop such infection after admission, 48 hours after admission. This is for nosocomial. We're not talking about ventilator-associated pneumonia till now. We're just speaking about the community acquired infection. Here is the mortality. PICU nosocomial infection has been estimated ranging from 5 to 11%. This is the international figure. About the VAP or ventilator-associated pneumonia, just shortly, ventilator-associated pneumonia means it is a pneumonia in a ventilated patient, right? So we cannot apply to a non-ventilated patient. Ventilated patient here, we are talking about invasive ventilation. I mean, if a patient on nasal CPAP, for example, so is not fitting the criteria to diagnose this ventilator-associated pneumonia. The diagnosis per se is a little bit difficult and vague, and it needs a lot of categories just to accumulate and make it in one cluster like this to diagnose community acquired nosocomial pneumonia or ventilator-associated pneumonia. So the patient either to be invasively ventilated, I mean intratracheal tube should be there, or even through tracheostomy tube. So either one of them should be there, and is a picture of pneumonia there, and we'll tell the clinical picture how it can be diagnosed. PICU nosocomial pneumonia occur in 6-13-fold in patient who require mechanical ventilation. VAP rate in children around 10 to 26% of the nosocomial infection. This is a 2000 definition. It is the development of a new pneumonia at least 48 hours after initiation of mechanical ventilation. A patient put in mechanical ventilator and at least 48 hours has passed, and then patient develop a picture of pneumonia. This is a 2000 definition. 2007 they have renewed the definition for the VAP. There is no minimum period for the time from ventilatory initiation. And I mean in the past the patient should be there on mechanical ventilator for at least 48 hours, and now they are telling any patient on mechanical ventilation, regardless the duration, and start to develop the picture of pneumonia with the criteria we're going to talk about, we can diagnose as VAP. Either it is early or late. From first day to 4 days of ventilation, we'll label it as early ventilator-associated pneumonia. If it is after 4 days, it is a late VAP. The rate of VAP the incidence per se have declined from 1999 to 2008 from 62.1 per 1,000 ventilator days because of this adoption of the preventive measures we are going to talk about. In Saudi Arabia, the incidence is a little bit still high, it is around 8.9 per 1,000 ventilator days. VAP again is the second most common hospital-acquired infection among pediatric and neonatal intensive care units. In some association actually for observation have been seen with the development of pneumonia, like wetted aspiration may be observed by a doctor or bedside nurse telling the patient has, after feeding or something, aspirated, some milk came out, and then some clinical deterioration start to happen, some deterioration of blood gas start to happen, and clustering of this information will give you a clue to the diagnosis of VAP. Some other instances like re-intubation or self-extubation. Some babies accidentally extubated and I'm going to re-intubate him again, and then shortly after which starts the patient to develop the symptoms and signs of pneumonia. History of prior antibiotics, patient on intensive care unit who was already on antibiotics, and the continuous enteral feeding, also one of the associated risk factor for the development of the ventilator-associated pneumonia. Is some of the organisms which are commonly encountered in the or observed by cultures like this for ventilator-associated pneumonia. One of the commonest organisms is the Pseudomonas aeruginosa. This is one of the commonest actually. Most of the ventilators, the humidifier is there, or again small tiny babies in the NICUs in a humid environment. Humidification is there, favoring the infection, especially with the Pseudomonas. Most of them are actually gram-negative bacilli like Pseudomonas, Entero, Klebsiella, Acinetobacter, or Haemophilus influenza. Or sometimes the gram-positive like Cons, coagulase-negative staph also can be encountered. Some other pathogens like fungal infection, for example, or anaerobic infection, but they are rare, they are uncommon, and may be observed only in immune-compromised patients like this. Maybe PICU, patient with multiple trauma, some syndromes with burns like this, or immune-suppressant medication. Why especially in mechanical ventilated patients? What are the factors help in development of ventilator-associated pneumonia while the patient on mechanical ventilator? As you see, the entracheal tube is just passing, and now it's breaking the barrier, breaking the normal immune system, one of the immune system for the upper respiratory tract, and making stenting of the trachea, allowing the organism to just migrate either in the form of microfilm, migration through the tube per se, or around the tube. Is usually after a while, for intubating the baby, there is colonization by normal bugs may be there. But because most of the patients are immune compromised, especially small tiny babies, or maybe because they are on medication, especially on antibiotic and other associated factors, organisms start to spread and invade the lower respiratory tract and start to manifest as VAP. So vocal cord, as we can see, it is stented, it's patent now, there is no protection anymore. Sometimes the gut per se is the incriminating source for this infection, especially a pH more than 3.5. I mean increasing the pH, and sometimes maybe it is a practice there to guard against reflux or apneas, and they are using the H2 receptor or antacids in general, and again we are increasing the pH of the gut, and this can help again to colonization of the gut. Sometimes there is reflux of these bugs. It is not that common, but it happens. So one of the factors for the development of this sepsis or this form of pneumonia is the use of antacids. So again, this is another message: be cautious about the use of antacids, generally speaking, especially for neonates. And again, colonization of the airways, as we said, 100% of the patient will be colonized within 5 days of mechanical ventilation. And this is a microfilm music. So the risk factors can be divided in two parts. Part can be avoidable actually, or we are saying modifiable, and another part is inevitable, we cannot modify. The non-modifiable, concerning the age, in extremes of age, especially small babies, extreme preterm with compromised immune system. If there's any immune deficiency, either patient part of genetic syndrome or by immune suppressive medication, especially in PICU personnel. Is there anything decreasing the drive, how the patient can get rid of his secretion, like neuromuscular weakness, or the use of heavy sedation or neuromuscular blocking agent, as we said in the previous lecture about the pancronium or other neuromuscular blocking agents. If the patient some loss of his normal immune system, sloughing the skin because of burns, for example, steroid medication, total parenteral nutrition, usually we have indwelling central venous catheter, and again this is a favor for infection. This is underlying chronic illness or surgery. Is modifiable or preventable or something we can control actually. And again we can go back to the previous lectures again. The duration of mechanical ventilation per se. As we said in the beginning, it's a matter of invasive mechanical ventilation. And as we said before, our priority now for ventilating a baby, just consider the non-invasive mechanical ventilation, namely the nasal CPAP, before considering, provided that circumstances is allowing us, before going to intubate the baby, because it's going to cost us a lot. One of them we are talking about is by trauma or by infection per se. And even if the patient got ventilated, inevitably we have to ventilate this patient. We have to shorten and minimize the duration of intubation or keeping him mechanical ventilation as much as we can. Always during our morning round, even by the bedside nurse is asking why to keep the patient now. Is the patient suitable ready now to extubate the baby? So the question should be there all over the time. Should we keep the baby on ventilator, or weaning should be flashing, lighting all the time? Should we wean the patient now or no? It's ready from the clinical point of view, from radiological point of view, from biochemical point of view, I mean the blood gas, for example. If things are favorable, just shorten the duration as much as we can, and just to go away and extubate your baby. Because the longer you are keeping the baby on ventilators, the more problems you are bringing to the baby. Again, justified use of antibiotics. Antibiotic per se, there is nothing called prophylactic antibiotic like this. Putting a patient on antibiotic for 48 hours, taking your culture, special time for admission. If culture proven to be negative, just stop your antibiotic. No need to keep antibiotic. It's not going to help you anymore. On contrast, no. On the other hand, maybe it is harmful. And on the level of the patient per se, on the level of your unit, sometimes, and actually many times, they are going to invite more resistant strains. And now they are responding to your ampicillin or gentamicin, and after a while, it will not respond anymore to your vancomycin even, and you will be in troubles. And now we can see a lot of multi-resistant organisms, right? And whatever antibiotic you are using, it is hopeless, doing nothing now. So justified use of antibiotic is very important. And again, the length of stay in the ICU. One of our bundle in the morning ground, as we said, about the central lines. Again, this is the same question we are asking, or the bedside nurse, even, or the RT or respiratory therapist is asking, do you need this central line, do you need this PIC line, do you need this umbilical, arterial, or venous line, or should we remove it? The shorter, the better. So long you are keeping the central indwelling catheter in situ, the more you are favoring infection and exposing your patient to a lot of troubles. Here's the one we just said about H2 receptor antagonist or H2 receptor blocker, antacids like ranitidine and cimetidine, these things. Again, we are increasing the pH of the stomach and help favoring or inviting colonization of the gut, and now inviting again for these bugs to invade the upper respiratory and lower respiratory tract and producing this pneumonia. About re-intubation, again, this is a matter of bedside nurse care. If the patient, and again we can return to our sedation, should not be fighting the ventilator because it's costing a lot. About intubation and re-intubation, again, it's observed many times after re-intubation of patient, especially if you are in rush and unfavorable situation, you are not following many times the infection control criteria. You are not maybe using some sterile gloves, maybe you are in a hurry, patient is desatting, is bradycardic, and so you are in rush, so you are breaking the sterile cycle and simply you are inviting infection. Sometimes you are even traumatizing the upper respiratory tract of the baby with your laryngoscope, and so inviting infection again. About transport patient out of ICU, some patients are going here and there actually. For some subspecialties, they are going for maybe eye assessment by ENT, by fiber optics, whatever, moving from here and there. And now again we are bringing some bugs from other units and maybe multi-resistant organisms as well. The nasoenteric tube, The present syndrome, it is inevitable again to keep a patient without nasogastric tube or nasoduodenal tube, but again affecting the lower esophageal sphincter about the valving system and allowing the reflux to take place there, and if the patient is colonized, the bugs can go and invite infection. Inline nebulization and manipulation of the ventilator circuit, again like central lines. For example, you are fixing a PIC line or umbilical venous line. It is not good practice to just interrupt the line every now and then to just give this medication and then connect again, and this is not the good practice. The good practice is just to keep it closed all the time. For example, I'm fixing TPN in this line, you need to interrupt it every now and then. The same for the ventilator cycle, ventilator circuit. The ventilation per se, instead of doing open suction every now and then, just disconnect the patient from ETT, put catheter, do suction, and then reconnect again. Again, every time you are doing like this, you are inviting infection again. So one of the common practice nowadays we are doing is the inline suction. Inline, the catheter is there all the time. Just we are introducing in a closed circuit. We are not opening, we are not disconnecting the patient from ETT tube all the time. Inline suction is there. It's better to do it most of the time. Inadequate infection control practices, I am telling, you have to follow our infection control practice and use of other medical devices. I mean, this is invasive manipulation of the patient. This is again some organism, as we said, the commonest organism to be seen the gram-negative bacilli, and namely Pseudomonas, E. coli, Klebsiella, and Enterobacter species, and the gram-positive organisms, especially the cons or coagulated negative staph. Some anaerobic organism and even fungal infection, mostly seen in adult or in pediatric age group, especially immune compromised individuals or those under immune suppressant medication. So this is the dilemma actually during our thinking of diagnosis and treatment of VAP or ventilator-associated pneumonia. Two targets are there. We have to avoid over treatment without VAP, because not every case to develop picture like pneumonia as a patient on ventilator. I'll label it as VAP, and in the meantime there should be immediate treatment of patient with VAP. As we heard in the previous lecture, patient for example with BBD or immune compromised patient, if he develops this pneumonia, simply you lose the patient very quickly. So we have to weigh things. We should not over-diagnose things, and in the meantime we have to intervene very quickly, otherwise it will be a bad outcome. These are our two objectives. So again, the goal is straightforward, but it is difficult to achieve. Because as we'll see now, to diagnose the VAP or the ventilator-associated pneumonia is not only one entity, or there is one diagnostic tool, for example, to go and diagnose ventilator-associated pneumonia. We have to find clustering of lot of things there, and with all, collectively we can diagnose ventilator-associated pneumonia. Have to have high index suspicion, especially with sick infants. So there are the three main golden criteria to diagnose the VAP or ventilator-associated pneumonia. Most important, number one, clinical diagnosis, number two, radiological, and eventually, which is not actually very important for the diagnosis per se, the microbiological criteria. Here, the demonstration of the causative organism, to know the causative organism per se, is necessary to direct the antibiotic therapy for the management per se, but for the diagnosis is not necessary at all. Because many times actually, as we'll see in a coming, maybe you'll not find any organism. Maybe you're just misled by our collection of the sample per se. Maybe you are just misled. Maybe a lot of colonizations there. As we said, after putting a baby on mechanical ventilator, colonized definitely. Once you take even tracheal aspirate, you'll find a lot of organisms there. Mixed flora may be there, and give you impressions that this is a responsible bug, and it is not. So clinical criteria, all of the time we are assessing the patient per se. We are not treating his X-ray, we are not treating his lab workup, we are treating the patient. So all the time we have to look to our patient. So we have to put in consideration the bedside observation, bedside nurse observation. The patient is not doing well. Patient is not behaving the same way. So there's some element of clinical deterioration. Baby is not doing well. Clinical deterioration concerning chest problem. Maybe the patient is tachypnic, in the form of tachypnea, increased respiratory rate. All of a sudden, some change has happened. Patient is tachypnic, and you go and check your patients. There may be some retractions there. And for auscultation, especially in pediatric age group, we found crackles or bronchial breathing. And so next step you are doing to do some bedside simple investigations from CBC, for example, and later on the X-ray. In CPC, we can find one of each. Newborn, actually, you have to consider leukopenia more than leukocytosis. Pediatric may be leukocytosis, especially more than 15,000, for example. But in newborn, we are interested more in leukopenia, especially if it is less than 5,000. Some secretion either changes the amount of secretion or change in the color of the secretion. The nature, the viscosity of the secretion is not as usual for the patient. We are doing our physiotherapy, our suctioning regular routine, and there's some changes there. Blood gas, there's changes of blood gas. Either you do observation in the pulse oximetry, the desaturation of the baby, there's increase in oxygen requirement. You did blood gas, maybe element of hypoxia is there, or hypercapnia as well. This has not got sensitive or specific, but just again in conjunction with radiology and microbiological function. Again, we are turning it as a matter of collective data, to not just simple clinical deterioration, for example, and I think is ventilator-associated pneumonia. So clinical, the most important. Number 2, radiological, and 3 is microbiology. Here's the X-ray findings, radiological findings X-ray. I know the X-ray findings of the patient. I have admitted the patient with RDS, for example. Patient has got chronic lung disease, BBD. I know his X-ray finding. With this clinical deterioration, I'm going to ask for an X-ray. X-ray will find some new infiltrates. So it's not his usual. Something new have evolved and happened as progressive infiltrates. Maybe because some atelectasis is there, I'll can see some air bronchogram. And the cavitation nematocele is actually very advanced, and you should not see this one for the first spot, because usually this is quite late. Here in the last right part of the slide, we can see that fever plus infiltrate does not necessarily means or equal pneumonia. There are some other differential diagnoses for this fever and chest radiological findings. Patient can have got some heart failure, some tumors, maybe pulmonary hemorrhage. I mean, a lot of differential diagnoses. We should not just give only one diagnosis. About the third item, we talk about the clinical deterioration of the baby. Second, about the radiological, and third, about microbiology. Microbiology, it is not the gold standard again. About the collection of the sample per se, it is a lot of debate is there, and it is difficult actually. Most of the time, for example, in our unit, we are not using so invasive procedure. We're just doing tracheal aspirate, and again, it may be misleading. For example, because of this colonization, simply you can just say contaminated sample may be there. But just to give us a background or a guideline, when I want to change antibiotic, I'm going to change maybe according to the coming bugs. But first of all, I'm going to start my antibiotic empirically, not waiting, of course, this microbiological finding. Other more invasive sampling in the form of bronchoscopic sampling, or not actually, is not something practical, just to go through fiber optic or bronchoscope and collect samples deep from the lungs. And actually, they found from postmortem or the autopsy finding, they failed to demonstrate insuperiority of one technique over the other. So it's obsolete now just to go for deep fiber optic bronchoscope to collect some samples and so on. Again, as we said, it's not important for the diagnosis per se to define the organism. It's not important. It is important to direct your course of antibiotic for how long you are going to use, what antibiotic you are going to use. But for the diagnosis per se is not important, because maybe up to 83% of cases you can't find cause of organism may be missed, or maybe just a contamination, as we said. Again, colonization may overestimate that. All clinical patients deteriorating, X-ray may be some changes, and again with some colonization of the intratracheal tube, and again give us some false clues that the patient develops this effect. This is again the different modalities of more invasive sampling in the form of bronchoscopic, non-bronchoscopic, bronchoalveolar lavage, and the last one is the tracheal aspirate. So for the diagnosis, they are telling these criteria, two first criteria should be there, and adding +2 of the following criteria. Patient should be ventilated, as we said why before. So patient should be in invasive mechanical ventilator, either intratracheal in situ or through tracheostomy. And second thing, radiological finding, patient develop a picture of pneumonia. Is new infiltrate, progressive infiltrated there, and development of air bronchogram. Adding to this, two of the following. Patient should have got fever, or we can say better temperature instability, because fever may be predicted more in pediatric age group. In newborn and so, maybe the patient can develop simply hypothermia. So temperature instability or fever more than 38. Here about the CBC or white cell count more than 12,000. And the third one, the tracheal aspirate or purulent tracheal aspirate more than 25 white blood cell per high power field on chemistry. This is actually the diagnostic criteria dependent on the age group. It is not our concern too much because we are focusing mainly in kids less than 1 year, but at least the radiological should be there, because I think 2 or more of serial chest x-rays, new or progressive infiltrate, consolidation of cavitations, I am telling it is a little bit quite late finding. In the infant less than 1 year, there is worsening of the gas exchange from hypoxia, hypercapnia is there, and at least temperature number 1, they are telling here temperature instability, as I'm telling is not matter of fever only, maybe hypothermia, and there is leukopenia, especially in less than 1 year. I'm talking mainly newborn less than 4,000, less than 5,000, we have to go in consideration. Pediatric age group more than 15,000 white cells was more than 10% bands, and some new onset of development of changing the color of the tracheal aspirate, changing into purulent color. Some clinical deterioration of apnea, tachypnea, nasopharyngeal. I mean, picture suggestive of pneumonia is there, and some cardiovascular instability. I mean, picture of sepsis per se may be there. About the treatment per se, the clinical guidelines for initial antibiotic therapy in VAP in children have not been published. There is no consensus or guidelines for the or a protocol to start what antibiotics start in a VAP like this. But once nosocomial pneumonia or ventilator-associated pneumonia is suspected, empiric treatment should be started. What kind of empiric treatment depends actually on the unit you are working in, because the bugs in my unit, for example, is different from your unit like this. So whatever antibiotic you are using in your unit, in a case suspect of sepsis, I have to start and not to wait. So long we have this criteria, as we said before, clinical, radiological, and this microbiological criteria. And again, you can start your antibiotic initially now, and maybe within 48 hours, culture may give you a guide or hint which antibiotic you are going to complete. So when specific or causative an infective agent is suspected, even sometimes by blood culture, we can change your antibiotic coverage. Here actually, this is, I guess this is the most important slide. When we are talking about strategies of prevention for the pediatric VAP bundle, we can see the hand washing or hygiene in general, or infection control protocol in your unit if it's implemented, or try to do as much as you can, even our personal level. So hand washing, just to break the cycle, not to contaminate things and spreading infection here and there. So they have adopted some bundle about the risk factor we've talked about before. We can avoid this risk factor, simple, and subsequently we can avoid this death. No need to wait it until it happens and then start to treat it. So to prevent iatrogenic spread infection, which I think is the most common in our units, we are the one who are spreading this infection to these innocent babies. First of all, adherence to good hand hygiene practice is not costing anything. Just wash your hands. Just wash your hands before going to your unit, before touching your patient, and in between your patient. And if you are not using just tap water like this with soap or any antiseptic substance, if you have some alcohol gel, just try to use it in between touching any patient. After touching the file of the patient, moving from one to one. Hand hygiene is very important and proven to be very, very effective in prevention of this costly infection. Can cost life and can cost a lot of money. Simple, just hand washing. And the use of universal precaution, universal antiseptic precaution. Just try to do all your intervention for your babies under aseptic precaution as much as you can. By very simple things, just avoid iatrogenic spreading of infection from your hands, from other patient, from the nursing staff, from files, from equipments to your baby. Use your appropriate isolation technique based on the infective organism, if it is suspected or it is proven. The simplest and the most effective, coming to the first category. Then some other simple procedures just to guard against this infection to happen. We talked about the reflux or passage of the gut from the colonized gut. We can just raise the head a little bit from 30 to 45 degrees. We have to monitor or drain this gastric content, again guard against passage of this gastric content up without secured upper respiratory and causing such infection. With decompression of the gastric tube, checking for residual. I think this should be a part of the practice, checking for residual, especially before any feeding or irregular pattern of the patient with MPO. And some item to improve oral hygiene, I think, is more practical for adult and older pediatric age group, like the use of chlorhexidine or antiseptic precaution of the mouse per se, not to colonize the mouse. Other items to decrease the intracheal tube risk factor. Again, the sentence we said about the inline suction. Again, it's a part of the equipment about the resources in different hospitals. So, but I mean, if it got available at a time in one unit, it will help a lot. Instead of breaking the circuit, the ventilator circuit every now and then just to suction and then reconnect things again, I'm inviting bugs to come in. But if inline suction is there, catheter is there, it can help a lot. Suctioning of the hypopharynx prior to intracheal suctioning and repositioning, just to keep it clean most of the time. Factors to avoid the contamination of the respiratory equipment. Prevention of the accumulation of the respiratory center of the respiratory circuit. I mean, this is the role of respiratory therapist, is available also in the unit. It's a very important item, very important part of the nursing care. And in natal ICU workup, the respiratory therapist, they have to take care of the circuit, because most of the time you are using humidifier, there's condensation, there's water vapor is there, accumulation of vapor. Again, if we turn back to the cause of organism, wet environment means pseudomonas all the time. So all the time we have to get rid of this vapor, we have to get rid of this condensed water in the respiratory circuit. There are some items to decrease the duration of mechanical ventilation. Again, we go back to the first lectures. We talk about the non-invasive ventilation, first thing. And again, whenever you put the patient on ventilator, think when to extubate the baby and remove him from mechanical ventilation. So it is a matter of daily assessment during our daily round. Actually, again, just to revise, corresponded just to avoid the iatrogenic spread of infection, prevent aspiration of the gastric content, always just keep the head elevated with 30-45 degrees. About this oral hygiene, intracheal risk factors, we said the closed intracheal suctioning system and positioning, and items to avoid contamination of the respiratory equipment. Just oropharyngeal suction equipment, prevent accumulation of fat circuit condenses, and prevention of contamination of the ventilator equipment. And again, the duration, we said the duration of mechanical ventilation. So as on a daily basis, we are going to assess the patient need for mechanical ventilation. Either we are going to continue just abort it and extubate your babies. If you remember the lecture about the sedation, I would justify the use of sedation, avoid the new muscle blocking agent, avoid the heavy sedation of the patient. The heavier the sedation of the patient, the prolonged duration on mechanical ventilator, and it's very difficult to be extubated. So it should be very justified use of opioids or the analgesic. Avoid the new muscle blocking agent, except in desperate situation, as we said. And again, the use of non-invasive ventilation, namely as we are talking about the necessity. Thanks. Is there any questions? Okay.
بعد حضرتك انا يعني مش عارفه اتخيل شكل الكلوز ديستراكشن سيستم، مش عارفه يعني هو معمول ازاي. قصدي حضرتك على اللي هو السايد واي سكشن اللي المفروض يبقى فيها مثلا
There's one connection, yes. Through the intracheal tubes, there's one connection there. There's one connection, yes. His line, the catheter is there all the time, and we're just No, actually it is outside and enclosed plastic bag like this, but it is closed system. And just we are during suction, just introducing. During suction, they come back again. So it is outside the Turkish tube.
مش ابلايد وده ممكن انا اساسا كولونايزيشن بس حضرتك احنا في تطبيق عملنا شغل جدا في اغلب رسائلنا كلنا وخلاص بقى دوكيومنتد دلوقتي ان انا اشتغل يعني الافكت بتاع الانترفير كاشوال وان انا استخدم اتف صح بتدي نتائج حلوه كتير قوي بتايدنتي ديجيتال كونديشن جنرال بعمل بلاد كاشوال بيبقى ستيرايل نيجاتيف كاشوال بس التركيه البوزيتيف ولما بستخدم حاجات باي انهيليشن ايفن دراجز باي انهيليشن زي ما عملت في السيستم جابت جود ايفكت.
You are right. Well, the message is that we should not wait. The message now should not wait. This culture is not important or vital for the diagnosis per se. So initially, just use your empiric medication, and then, as you said, just direct your culture, your antibiotic medication or regime according based on the new culture. For example, you have got both blood culture, both of intracheal culture. We are going to change according to this culture, provided that other criteria are there. I mean, this clinical is there and radiological, as you said. Some new infiltration is there, and you found some bug there. It's not a matter of just colonization in the intracheal tube. We can use it and get very good result. I mean, practice per se we are using like this.
فلاحظ انه بتفضل دايما recurrent problems بالنسبه للواحد يحس ان في اتاك في النيوترولوجي the first few months عنده recurrent attacks في pneumonia. مش عارف السبب ايه اولا وهل في حاجه ممكن تستفاد في
I don't know. يعني newborn per se, maybe you are talking about some special age group. If you are talking about preterm babies per se, is with recurrent pneumonias.
follow up post discharge.
post discharge بعد كده في first 6 months طبعا مور اكتر في البريتيرم انه بيحصل لهم recurrent attacks of pneumonia كده.
I think you have to explore. This is abnormal. Yeah, to patient to have gotten 6 months, for example, recurrent pneumonia, there's something wrong there. As a general speaking, immune compromised patient is a part of prematurity per se, and is not also justified. Yani even if a preterm baby, I'm not expecting him to have with good care to have repeat infection. Or there's some local thing there may be missed, or some congenital anomalies, association, some of the post-op cases, for example, this patient with geriatresia with fistulas and post-op and the development of some percumulatia, and they are more susceptible actually. The patient got some central insult, for example, and cannot deal with the secretion, and the possibility of aspiration is there. I mean, we have to explore and search more for, but for straightforward cases, I don't think they will develop recurrent attacks unless there's something wrong there.
بيأفكت تي هيلبر تي سيلز بيأفكت الجهاز السيستم either injection intubation venous catheter او mechanical catheter whatever اي maneuver بيأفكت تي هيلبر والسيركل سيستم later on ده بيجي ده بيبقى ده من الحاجات الهازارد اللي later on قدام حتى لما عملنا الدي دي اي والدي اي later on بيأفكت المانوفر اللي بتحصل.
Yeah, this is a contributing factor. يعني this can explain. Yeah. But I mean, in practice, we are following up our micropremies even in our OBD, in our clinics. We are not facing actually these problems about recurrent pneumonias per se too much, unless if you have got some RSV, for example. And we are syncytial viral infection, especially in the winter season. So, yes. And we are adopting some vaccination program in our unit there about the vaccination of these small babies with RSV vaccine and prior to discharge. And bronchiolitis. This is the point. Yeah, many times it's not just you're talking about T cell and so on, about the bacterial pneumonia and so on. Because many times it's just simple viral pneumonia, adenovirus or syncytial virus, and it's diagnosed many times, and they are admitted actually too many times in PICU, our graduates I mean from NICU. But the incidence much declined after this adoption of our program for RCV vaccination. Yes. It is very expensive, but again, we are weighing benefits, and it is very expensive, yes, but it can help a lot. No, actually, the protocol, our protocol for RCV, you mean? No, you are talking about the protocol for RCV vaccination. For whom?
No, I'm sorry. I explain about this way culture or examination for the virus. Any case of pneumonia after the baby discharge during the first week of life. Culture sensitivity for this virus. Any baby?
Not any baby, if it's admitted babies, yes. And sometimes actually in ER, even without admission. If they are suspecting this one, they are just taking oropharyngeal swab, and they are doing some cascade for actually maybe 6 viruses, including Haemophilus influenza and adenovirus and RSV and I think nearly 6 or 7 viruses like this by direct fluorescence technique. Thanks.